So the topic of my lecture today is the use of a novel agent, namely Tirzepatide, across the cardiometabolic continuum. I do not have any conflict of interest to declare regarding this lecture. And almost 1 year ago, in November 2023, we were introduced for the first time in the term of cardio-kidney metabolic syndrome. We were introduced for the first time into the term of cardio-kidney metabolic syndrome in November 2023, according to a presidential advisory published by the American Heart Association. And cardio-kidney metabolic syndrome is defined as that health disorder that interconnects diabetes, obesity, cardiovascular disease, and chronic kidney disease. And practically, CKM syndrome is classified into 4 stages. In stage 1, we have individuals with overweight or obesity and prediabetes. In stage 2, we have individuals with metabolic risk factors such as type 2 diabetes, hypertension, dyslipidemia, CKD, and or metabolic syndrome. In stage 3, we have individuals with subclinical cardiovascular disease, and in stage 4, individuals with established cardiovascular disease and at least one metabolic risk factor. And according to a recently published retrospective analysis from the United States, almost 90% of the population in the United States can be classified into 1 out of 4 stages of CKM syndrome, with most patients, almost 50% of them, being categorized as having stage 2 CKM syndrome. Regarding the individual components of CKM syndrome, we know that diabetes mellitus is a global ongoing pandemic affecting 1 in 10 adults. And we know that in 2021, we had more than 500 million people worldwide suffering from diabetes mellitus. And we are going to see an exponential increase by almost 50% within the next 2 decades. Whereas we also know that overweight and obesity is constitute another ongoing epidemic. In 2022, 1 in 8 people in the world were living with obesity, and 2.5 billion adults were either overweight or obese. And the result of all those is that atherosclerotic cardiovascular disease, which remains the #1 cause of death worldwide. These are some data from the European Society of Cardiology referring to individuals from European Union where cardiovascular disease represents the major cause of death, affecting and leading to death in about 1/3 of population and resulting in 1.8 million deaths each year. And what is Tirzepatide, which has attracted scientific interest during the last years? Tirzepatide is the first novel dual receptor coagonist of glucagon-like peptide 1, in other words, GLP-1, and gastric inhibitory polypeptide, in other words, GIP receptor coagonist. Practically, it is a molecule that has some certain similarities in terms of its structure, but also some certain differences with traditional classic GLP-1 receptor agonists like exenatide or exendin 4, which is the first GLP-1 receptor agonist to be produced. And we know that GIP and GLP-1 are the 2 major incretin hormones. GIP is secreted by K cells in the small intestine and GLP-1 by L cells. And we know that they mediate the incretin effect both in healthy individuals and in individuals with diabetes mellitus. And we know that in individuals with type 2 diabetes, we have a progressive reduction in beta cell mass, resulting in reduced production of insulin. And on the other hand, we have a reduced expression of GIP receptors. And these are the 2 major mechanisms that result in the worsening of glycemic control, glucotoxicity, and progression of diabetes and development of diabetic complications. And regarding its effects in our body, we know that GIP also is a significant secretagogue of insulin secretion. However, it enhances glucagon secretion in contrast with GLP-1, which downregulates glucagon secretion, whereas GIP does not have any significant effect on gastrointestinal tract or on kidneys. We also know from data from experimental studies since a decade at least, that there is an additivity of insulinotropic effects of GIP and GLP-1. This is an experimental study published in 2011 showing that subsequent administration of GIP and GLP-1 in individuals serving as healthy controls and in individuals with type 2 diabetes had the same impact on insulin secretion with the co-administration of GLP-1 and GIP. And what about the main effect of GIP? The main effect, biological effect of GIP is focused on white adipose tissue, where it enhances the activity of lipoprotein lipase, enhances the conversion of triglycerides to free fatty acids and glycerol, enhances the uptake of glucose and free fatty acids from white adipose tissue, and reduces ectopic triglyceride storage, and thus results in a significant reduction in visceral fat. And of course, we know that as seen with the GLP-1 receptors, also the GIP receptor is expressed in hypothalamus in certain hypothalamic nuclei that regulate satiation and appetite, and therefore co-agonism of GIP and GLP-1 receptors might have an additive effect on suppression of appetite centrally. What about the clinical evidence of tirzepatide across the cardiometabolic continuum? Regarding its effects on type 2 diabetes, we have evidence from large randomized controlled trials and a nice meta-analysis by the team of Professor Chapas, led by Professor Karagiannis, published in 2022, that showed that tirzepatide results in a dose-dependent manner in a reduction, in a significant reduction in glycated hemoglobin levels, whereas tirzepatide is superior across all dosing regimens to GLP-1 receptor agonists in terms of glycated hemoglobin reduction, and the same applies to body weight reduction, in which it was shown that tirzepatide across all doses had a significant effect on body weight reduction compared to placebo or compared to GLP-1 receptor agonists. And in the same meta-analysis, it was also documented that tirzepatide does not affect the risk of any or severe hypoglycemia, and this is also an important finding, while in another meta-analysis of relevant trials, we demonstrated that tirzepatide also reduces albuminuria among individuals with type 2 diabetes. However, when we compared tirzepatide to GLP-1 receptor agonists, we did not find any significant difference in terms of albuminuria reduction. And based upon the findings of another recent network meta-analysis by Professor Karagiannis, it is evident that tirzepatide far outperforms the most potent GLP-1 receptor agonist, namely semaglutide, in terms of glycemia improvement and in terms of body weight reduction. Therefore, tirzepatide, especially in higher doses of 10 and 15 milligrams once weekly, it is superior to semaglutide regarding reduction in glycated hemoglobin levels and body weight. Of course, as seen with GLP-1 receptor agonists, we have also gastrointestinal adverse effects of tirzepatide, namely nausea, vomiting, and diarrhea. Individuals taking tirzepatide experience a 3- to 4-fold increase in the odds for gastrointestinal adverse events, and this results in a 2-fold increase in the odds for treatment discontinuation. However, as seen with GLP-1 receptor agonists, also individuals taking tirzepatide have transient gastrointestinal adverse events that resolve with ongoing treatment. Regarding other safety concerns of interest in type 2 diabetes, we have shown in a recent meta-analysis that tirzepatide does not affect the risk for diabetic retinopathy, whereas despite the fact that evidence is really preliminary and based upon some reported serious adverse events, we do not have any concerns regarding its use in type 2 diabetes. And therefore, all those findings led the FDA to approve tirzepatide for the first time in May 2022 for the treatment of type 2 diabetes. And it was incorporated into the treatment algorithm of type 2 diabetes according to the consensus document by the American Diabetes Association and the European Association for the Study of Diabetes. What about its effects on overweight and obesity? These are the results of the hallmark SURMOUNT-1 trial, which demonstrated a significant reduction in body weight with all doses of tirzepatide, reaching up to 21% with the highest dose, that of tirzepatide 15 milligrams once weekly. And this is an impressive effect in terms of body weight reduction. Whereas in another important trial in the field, in the SURMOUNT-4 trial, it was shown that individuals with overweight or obesity taking tirzepatide lost about 21% of their baseline body weight after 36 weeks of treatment, and then those that continued treatment with tirzepatide finally achieved, after 88 weeks, a 25% reduction in their body weight, which practically reaches up to the effects seen with metabolic surgery. And as seen in type 2 diabetes, also in overweight or obesity, tirzepatide is superior to the highest available dose of semaglutide for the treatment of obesity in terms of body weight reduction. And therefore, in this battle, we have once again tirzepatide as the winner. Also, recently published real-world data suggest and confirm that tirzepatide is superior to semaglutide in terms of body weight reduction. These are the results of a study published almost a month ago in JAMA Internal Medicine, and it is noteworthy to mention that among individuals without baseline type 2 diabetes, an 18% reduction in baseline body weight was seen after 12 months of treatment. And it is also noteworthy to mention that individuals without type 2 diabetes at baseline achieved a greater weight loss compared to individuals with baseline type 2 diabetes. And therefore, another one approval for tirzepatide for Mounjaro by the FDA, which approved tirzepatide for chronic weight management for individuals with obesity or overweight in November 2023. What about tirzepatide and cardiovascular disease? We do not have any solid evidence to date. However, these are the results of a former meta-analysis published in Nature Medicine in 2022, which showed that tirzepatide is at least cardiovascular safe, according to evidence retrieved from the SERPAS clinical trials program. Whereas 2 weeks ago, we had a publication in JAMA Network Open showing that tirzepatide compared to classic GLP-1 receptor agonists result in a 20% reduction in the risk for MACE and a 24% reduction in the risk for MACE or all-cause mortality, along with an impressive reduction by 42% for all-cause death among individuals with type 2 diabetes. Of course, we have to wait for the results of the SERPAS CVOT trial, which has been completed, and its results are eagerly anticipated. This trial enrolled more than 10,000 individuals with type 2 diabetes and atherosclerotic cardiovascular disease. Half of them had coronary artery disease, 15% of them had prior stroke, and 25% of them had peripheral artery disease. And it is noteworthy to mention that this is one of the first cardiovascular outcome trials comparing head-to-head two different drugs with potential cardiovascular benefit. And regarding cardiovascular safety and efficacy in individuals with overweight or obesity without type 2 diabetes, this is a post hoc analysis of the SURMOUNT-1 trial, which showed that tirzepatide in individuals with overweight or obesity can result in a 20% reduction in the 10-year atherosclerotic cardiovascular disease risk. And of course, we have ongoing trials. We have an ongoing trial with tirzepatide regarding the reduction of cardiovascular morbidity and mortality in adults with obesity without baseline type 2 diabetes. And in August 2024, we had for the first time some information regarding the SUMMIT trial, a trial that enrolled individuals with obesity and HFpEF with and without type 2 diabetes, which showed that tirzepatide compared to placebo resulted in a 38% reduction in the risk of the primary heart failure composite outcome. And of course, we have to wait for the official results and the publication of this trial. What about chronic kidney disease? We showed that tirzepatide reduces albuminuria levels in individuals with type 2 diabetes in a dose-dependent manner without significant differences between doses, and it is also successful in reducing albuminuria levels in individuals with high baseline albuminuria levels. And it is also noteworthy to mention here that tirzepatide is superior to GLP-1 RAs in terms of albuminuria reduction. However, there is no significant effect on eGFR levels. And today, there is no trial assessing the renal efficacy of tirzepatide. However, we have some data from the SERPAS-4 trial, which demonstrated in a post-hoc analysis that tirzepatide compared to insulin glargine reduced by 42% the risk for a composite renal endpoint, including doubling of serum creatinine and progression to end-stage kidney disease. Of course, we have also ongoing trials regarding the renal efficacy of tirzepatide, the TREASURE-CKD, which enrolls individuals with or without type 2 diabetes, with obesity and chronic kidney disease in order to assess its effect on hard renal endpoints. Of course, we also have significant reductions in systolic and diastolic blood pressure with tirzepatide compatible with body weight reduction, whereas we have also data from an ABPM sub-study from the SURMOUNT-1 trial, which demonstrated that tirzepatide reduces 24-hour ambulatory systolic and diastolic blood pressure in individuals with overweight or obesity, and this effect is independent of major baseline characteristics of interest, including hypertension or usage of antihypertensive medication. What about dyslipidemia and tirzepatide? We do not have a significant effect on LDL cholesterol levels. We have a slight reduction, however significant, in triglyceride levels in individuals with type 2 diabetes or overweight with obesity. And finally, we have two significant trials published recently in New England Journal of Medicine. The first one assessed the efficacy and safety of tirzepatide in individuals with MAS, with metabolic dysfunction-associated steatohepatitis, which demonstrated that all doses of tirzepatide resulted in a significant effect in terms of NAS resolution without worsening of fibrosis, along with a significant reduction in aminotransferase levels among all enrolled participants. And this is reflected into the recently published clinical practice guidelines by EASL, EASD, and EASO. And of course, we have also one trial in obstructive sleep apnea syndrome, the SURMOUNT-OSA trial, which demonstrated a significant reduction in apnea-hypopnea index with tirzepatide compared to placebo in individuals with overweight or obesity and established obstructive sleep apnea syndrome. Therefore, to conclude, I think that tirzepatide appears to be a powerful weapon against the ongoing cardiometabolic pandemic. Tirzepatide practically is the most efficacious based upon data from randomized controlled trials treatment option for tackling the obesity epidemic. Of course, we do not have any solid evidence from dedicated trials in terms of cardiovascular and renal efficacy, and we have to wait for the results of those ongoing and completed trials to be published within the next years. And of course, we need cost-effectiveness analysis because tirzepatide is a wonderful and impressive drug, but it is also very, very expensive. Thank you for your attention.